Good morning, everybody. Why is everyone so quiet?
We were waiting for you.
Oh,
Good morning, Dr. Namrata.
good morning. I thought everything was muted. Why is not anybody speaking anything?
We were pranking you.
Oh. No, we have 3 more minutes.
Yes, 3-4 minutes. Yeah.
I can't see the new look. Whose new look was people?
Very
Everyone-
nice.
Okay. I think he's. We have 2 more minutes. Are we going to sit in pin drop silence?
You can go ahead.
Oh, I saw Dr. Vinay's new look. Yes.
There I am.
Yeah. Nice look.
Thank you.
Dr. Vinay was saying that there's Ganesh festival. So, they are really worried that COVID might pick up again.
Oh, yeah.
Apparently, one of the mandals refused to hold a aarti unless public was allowed.
Oh. I don't think we'll ever change.
I don't think we will.
Hmm.
और learnings थोड़े time के लिए रहता है उसके बाद again
कुछ नहीं रहता है यार, वो थोड़े दिन मतलब लिटरली जब भरा हुआ रहता है ना हॉस्पिटल, तब लर्निंग रहती है.
No, but that's true everywhere. Even in the US, you have a significant number of population who don't want to get vaccinated.
No, but see, Rajesh, not getting vaccinated is a conscious choice.
No, but conscious choice in the sense there is resurgence in the US, and they have.
I agree, but here we are
because of the
basically
people who
ignorant.
are unvaccinated.
Here, even the vaccinated people behave the same.
Shall we start? Okay. Good morning, everybody. And I would like to welcome all of you on behalf of Cornea Society of India. Thank you very much for spending your valuable Sunday morning with us, and hope we make it count. With this thing, I would like to invite Dr. Vikas Mittal to conduct this episode of Kerakonnect Keratoconus Near Live Clinic. Vikas, over to you.
Yeah, thanks so much, Himanshu. So I'll just share my screen. Thanks so much and welcome everyone on this ongoing ECME series of called Kerakonnect. And this time we are doing it on a Sunday. And the topic today is Keratoconus. So when we were discussing about keratoconus, we thought that maybe we can bring out some new format, and we are trying a different format this time. And the topic keratoconus, we all know that it's not only cornea surgeons who see this, even the general ophthalmologists, refractive surgeons. So it's a very in cornea surgeons clinic is a very common thing, but in general ophthalmologists also come across keratoconus every now and then. There are many questions, many issues. So we thought that we'll discuss all of them or most of them in this particular session. The unique format is near live keratoconus clinics. So what we'll try to do is create a virtual clinic, and then we'll pick up the issues from there and then discuss with our fantastic panelists that we have. We have 3 cases for this particular part of Kerakonnect program. And this is divided, each case will be divided into 2 parts. First will be virtual clinic, which I said, as I said, will be followed by a panel discussion. In the virtual clinic, there'll be patient and general ophthalmologist who would be taking an opinion from a cornea specialist. And once that conversation gets over, moderator will pick up the issues from that particular case and discuss with the panelist, and will also show what is there in the literature on that particular issue. We have fantastic panelists here, who have been into keratoconus, managing these keratoconus for more than 2 decades now. Dr. Srinivas Rao from Chennai, Dr. Praveen Krishna from LVPI Hyderabad, Dr. Rajesh Fogla, Senior Consultant Apollo Hospital Hyderabad, Dr. Namta Sharma from RP Center, and Dr. Vinay Agarwal from Mumbai. So the cornea specialists who will be giving their opinion in the virtual clinic are Dr. Charuta Puranik from Hyderabad, Dr. Sonia Kothari from Mumbai, and Akanksha Sinha from Kanpur. So without wasting more time, let's start our case 1. In case 1, the patient role is played by Yatri, and general ophthalmologist will be Charuta, will be Darshana Rothor, who will be taking opinion from Charuta Puranik. So over to you, Dr. Darshana.
Thank you, sir. Good morning, Dr. Charuta. Thank you for consenting and helping me out with this patient. So she's 13 years old female patient who presented to me with complaint of diminution of vision in left eye since 1.5 years. Also, she gives history of frequent change of glasses and eye rubbing. She also gives positive family history of sibling with diagnosed keratoconus and who has already undergone CXL. Her refraction shows myopic astigmatism in both eyes. Right eye is improving to 6.6 and left eye is improving up till only 6.9. Rest anterior segment and posterior segment appears to be within normal limits. So I went ahead and did pentacam for her. Her right eye pentacam shows steepest keratometry readings of around 48 diopters. There is some superior inferior asymmetry as well. And I could see that there is thinnest pachymetry of around 488 microns in the right eye, and left eye pentacam shows steepest K reading of around 50 diopters. Here the superior inferior asymmetry is little more, and thinnest pachy is around 470 microns. Now this is the right eye bad map, and now this is the left eye bad map. So ma'am, how should I approach? Like, this is a case of keratoconus, and should I go ahead with CXL?
Oh, hi, Darshana. How are you? How was practice?
I'm all good,
I heard
ma'am.
you had,
After COVID, it's
yeah,
good.
have a lovely high volume practice. So very interesting case you've shared with us. So I know that you said there is some sibling history.
Yes.
Did you take a look at her maps, or is there any history of progression in the sibling?
Yes, ma'am. I saw her pentacam maps. I don't know about the progression because we just have one pentacam map which she showed me. This is the right eye pentacam of her 16 years old sibling, which shows severe advanced keratoconus with pachy of around 450 and 64 diopters steepness. And this is the left eye of her sibling with, again, advanced keratoconus and pachy is around 450 microns, and already CXL is done.
Yeah, okay. So, I mean, of course, you know that in the left eye, we can frankly see that there is some keratoconus. And given the family history of keratoconus, cross-linking being done in the sibling, and basically her age, I think there is a very high risk that she's going to progress in the left eye. So I know there are a lot of studies that have published their outcomes in pediatric keratoconus. And maybe it's a good idea to go ahead with cross-linking the left eye right away, rather than wait and watch. So although Dr. Hafizi's group has recommended that you document the progression, he also recommends that you go ahead and cross-link it first, right away. So maybe in the right eye, it's a good idea to, if you see the bad map of the right eye, it's a little suspicious, the PTI is suspicious. And like you rightly pointed out, even there's some SI asymmetry. So give a very close watch, like maybe just repeat it after 6 weeks also, because these tend to be very aggressive in the young age. And of course, associated with the family history and the history of eye rubbing.
Okay, ma'am. Ma'am, is it safe, like CXL in this age group?
Yeah, I mean, pediatric cross-linking has been reported to be safe. I mean, my own personal experience is limited to a few cases, but they have shown it to be very safe, effective also, leads to an improvement in the visual acuity also. Of course, like in adults, we do see haze, but there's no other serious side effects that have been documented.
And ma'am, which protocol should I go ahead? Like I usually go ahead with Dresden protocol, and which anesthesia, because she's 13 years, I'm very much concerned. Like how should I plan?
Yeah, that's a very important practical question, because is the patient cooperative? Do you think she'll cooperate to do under topical? Yeah, so you could like keep talking to the patient during surgery and allay her fears beforehand. So 13 is a good enough age for us to talk to the patient, do it under topical. But general anesthesia can be considered in some cases. Regarding the protocol, actually, the Nara Netralaya group has published their outcomes of an accelerated cross-linking. I think that would be a good idea, because it really reduces the time required. Just in 40 minutes, you can finish the procedure very effectively also. Epi on cross-linking also has been considered, although it causes less pain, but it also sort of leads to less reduction in the standard key. So, and there's some variable penetration. So I think accelerated cross-linking would probably be a good option.
Okay, ma'am. And patient is like going to school these days and like requesting whether she could postpone it for like few months up till vacations, like Diwali vacations are coming up. So how should I like go ahead? Like I want to plan like entire thing, like left eye CXL, then right eye CXL, or whether I can wait for left eye as well. What is your opinion, ma'am?
I think it's a good idea to go for the left eye CXL right away, because we know that there's a 7-fold higher chance of it needing transplant if left, and very fast, they progress really aggressively. So maybe left eye, at least we could go for it right away. Right eye, like I said, a close watch would be better, but you can always take the family into confidence, and they would have their own practical problems, and exams and schools are also equally important, but you'll have to take them into consideration, take a collective decision, but don't delay it.
Okay, ma'am. Thank you so much. I have my patient's niece along with me, and she has a query. So I'm just asking her to like communicate.
Oh, sure. That's great. Yeah. I'd love to talk to you.
Yeah, Yatri, you can please
Good morning,
ask.
ma'am. Thank you,
Hi.
Dr. Darshana, for consenting such a valuable opinion for my patient. Good morning, ma'am. I wanted to ask if my patient would be able to see clearly without spectacles after the surgery.
Oh, that's a very good question, actually. So we're doing the cross-linking. The aim of the cross-linking would be to arrest the progression. So we are anticipating that probably the keratoconus would worsen with time and very fast. So the goal of the treatment is only to flatten it. It's not to get rid of the number at this point. But although a lot of studies have shown that after a period of 3 months to even up to 3 years, the corneal shape keeps becoming flatter and flatter. So we could anticipate that the number required would be lesser and lesser. But the plan for her vision would be that we could do a rigid lens trial after 3 months, like it was done before for her. We could just repeat it at 3 months after the cross-linking. And then take it as it comes. We could follow up closely every 3 months, see what are her visual requirements, if she's improving on it.
Okay.
Okay.
Thank you, ma'am. And as I could understand, my patient has disease in both the eyes. So if we are going to operate only for left eye, will her right eye be fine? Are we doing right for waiting about the other eye?
So progression is dependent on the genetic factors, and probably we need to document progression, or even because in the right eye it's an early case. So it would be really beneficial to know how much it's increasing, because it can tend to be more on one side. I would rather wait and watch in the right eye.
Thank you, ma'am. Thank you so much for your
Thank you
time.
so much.
Thanks a
Thank you,
lot.
Dr. Krishna.
Thank you.
Thank you, Dr. Darshana. Bye.
Bye. Bye, ma'am.
Thanks so much, Darshana, and thanks so much, Charuta, for this lovely conversation. So we have in this first case, so we have a pediatric keratoconus who has a history of frequent change in glasses, family history, very strong family history, eye rubbing, and 6/6 in one eye with decent pentagram, not really bad, and advising CXL one eye. Dr. Charuta said we will advise CXL in one eye, and second eye also might need. So we have a few issues here. How does family history affect our decision making, and is it okay to do a cross linking in a kid with 6/6 vision, or is there any issues? How do we actually define progression? She said that the child had frequent change of glasses, so is it okay enough to take this as a progression? How do we really deal with that? And the next is, how do we, as Darshana asked, that what is the protocol, which protocol in children, is it different from adults? And since in the survey we found the youngest child people have done cross-linking in is close to 5 years. So suppose you do a cross-link in 5, 7, 10 years of age, will it need a repeat CXL also? And the last is, this child had a 6/9 vision. Had it been 6/12 or 6/18, so you might need a contact lens. So contact lens fitting, is it different from adults? Let's go ahead and ask these questions and discuss it with our panel. So our first question is for Dr. Vinay Agarwal. So do you generally screen siblings or parents of your patients, and will you do a LVC in a sibling of keratoconus? Before you answer, so I'll just show you that there were less than 25% of respondents. They actually found that there was a positive family history in the patient of keratoconus. Darshana, can you just show what is there in the literature?
Yes, so there is very little literature available on this topic, but there is one huge study named CLEC study, Collaborative Longitudinal Evaluation of Keratoconus, which studies around 1,000 patients, and which shows that there is 13.5% of patients who are reported with family history of keratoconus. So which shows the prevalence in this study. And this is another study, which is a review article, which shows 3 to 31% of first degree relatives had keratoconus. And this study also shows that being a first degree relative of a subject with keratoconus remains a risk factor for developing keratoconus. This is very important while screening for keratoconus in pediatric patients for refractive surgery candidates. So we could see from this entire data that siblings and parents are strongly associated with keratoconus, and there are a few genetic studies as well which shows us association of genetic variation with keratoconus.
So Dr. Vinay, if the patient comes in your clinic, so do you tell them to bring their siblings also? How do you generally do it in your clinics?
Essentially, there are a couple of things which I have realized over the years. One is that there is an absolute lack of information amongst our patients, even those who have a frequent history of change of glasses, or even if they come to you with a diagnosed keratoconus. So we make it a point to talk to all our patients and inform them that keratoconus can have a genetic component. And I do suggest to the patients that the relatives should get their evaluations done. The problem with many patients is that their immediate family may or may not be with them, or may not be willing. That is my major problem. But we do advise all our patients that they should have a screening done. And we have found approximately 10 to 15% correlation. What is equally important to understand is that even those who are siblings not demonstrating keratoconus, forme fruste is a higher percentage than what I have seen in the studies which have been documented. The reason for that is, according to me, these studies are all based on Caucasian profiles. whereas the Indian keratoconus profile to me seems to be a little more aggressive than the Caucasian profile. To answer
Great.
your second question, I would not offer laser visor correction to a sibling of a keratoconus patient.
Great.
13%, which is there even in the Caucasian history, is an unacceptable risk of progression in these patients. And as I said, I believe that the Indian scenario is a little more aggressive, though we don't have enough data to comment on it. But over the years, that's what I feel, that the Indian performance of keratoconus is more severe compared to Caucasian.
Great. So what you are trying to suggest, or what we are seeing in the literature, is there's still not enough evidence, but looks like that we should have a baseline pentacam or topography done of a sibling of a keratoconus patient.
Yes.
And what you are also suggesting is you need to be cautious while advising a LVC for a sibling or at least first degree relative of keratoconus. Great. I think that's a very good takeaway. Let's go to the second point. CXL in a kid with 6/6 vision. So the one eye was 6/6. So do you want to wait or go ahead with the CXL? How can you wait? What is, Dr. Fogla, what is your threshold for prescribing CXL in children?
Well, compared to adults, we know that the risk of progression of keratoconus is higher in children, especially if there is coexisting allergic eye disease present as well. But we have to keep in mind that if somebody is already correcting up to 6/6 and performing a cross-linking, there is always a risk that the quality of vision can deteriorate. Somebody who's 6/6 can become 6/9 or 6/12 post-cross-linking as well. So this has to be discussed with the parents because they need to know what are the risks involved with the cross-linking procedure. And for me, at the first visit, if I have in the previous records, if I note that there is a progressive increase in the astigmatism, because the spherical power can change even just as the child grows, but if the cylindrical power is worsening over the past, few months, years, and if they don't have any previous topography, that itself is an indirect evidence of progression, based on which I can discuss with the parents that it may be prudent to do the cross-linking procedure in the eye which is worse affected. And if not, if I don't have an evidence, maybe I will treat with lubricants, maybe anti-allergic medication, review the patient in 3 months. And if I feel that there is a documented change, then I'm justified in going ahead and doing a cross-linking procedure for the child.
So when, if like this patient, if you have a patient child who has an allergy also, so do you want to ensure that the allergy is quiet before you take up the patient
Yes,
for CXL?
absolutely.
And,
I think.
and do you see any difference in healing pattern in CXL with BKC versus CXL with plain Keratoconus?
I think the chances of a failed CXL would be higher if you were to perform it in an eye with active allergic eye disease. But if you were to control the allergic eye disease and then perform the cross-linking, you may have better success rates. And the other thing is that you will not have the epithelial healing problems that can sometimes happen post-cross-linking. So if somebody is, because the child has to stop the eye rubbing as well. And I think it's important that that may be the triggering factor for the progression of keratoconus. And if you can control that, maybe you will definitely have much better outcomes when the cross-linking is performed.
Great. So I think message is pretty clear that we need to have low threshold for advising cross-linking in children, and especially when we have a strong family history or VKC. Is that correct, Dr. Fogla?
Yes, absolutely.
Great. Thank you so much. So you said that, we need, you look at the prescription. If the astigmatism is increasing, you would like to label it as progression. And then Charuta was saying that she would like to see, document, and then decide whether it is progress or not. So how do we actually define progression? When do we actually label that, is it based on refraction or topography? And then how reliable this topography in children? Sometimes they are not very cooperative. And how reliable is refraction in children, and how reliable is refraction in keratoconus per se? So this will be the question to Dr. Praveen Krishna. And before he takes up this, so I'll just like to show you, Darshana will show you what is there in the literature. Darshana?
So we tried to review articles both on topography and refraction. So this showed that there was no global definitive criteria for keratoconus progression and the need for CXL. Also, we saw that K-max, that was the main indicator to define progression in keratoconus, which was suggested by multiple articles, multiple studies. And we have one new tool like ABCD keratoconus grading system, which is published recently in Cornea 2021. The ABCD keratoconus grading system, which is all they took into account multiple other indicators like anterior and posterior curvature, thinness, Pecky values, best spectacle corrected distance, visual acuity, and presence of corneal scarring, also as parameters to measure progression of keratoconus. And this was all related to topography and related to refraction. There was a huge study which we talked about before as well, CLEC study, which showed that the retest variability is very high in keratoconus, and it showed that it was 4 to 6 times larger than in normal myopes. Like the retest variability in refraction in keratoconus was this much higher.
So that means, Praveen, in case the patient is carrying few prescriptions and it has a different, glass power, so we don't know whether to rely on it or not. That's what, literature says. And then in topography, what all we actually see. So there's a confusion. So I think you're the best person to answer that.
I think I would like to answer the question in two parts. One is, I think, with respect to adults, because change in refraction is something that probably is easier to measure in adults, more reliable. You don't have a myopic shift there as well. Whereas change in refraction in children could have many connotations and many reasons as well. For that reason, and also because of the fact, like Darshana mentioned, that ability to get a reliable, repeatable refraction, even on the same day by the same person, there is so much variability. So refraction is something that we don't consider at all when we are trying to assess progression, both in children and in adults. Now, what parameters do you consider? Probably topography is the most reliable objective parameter to consider when you're considering looking for progression. Now, what about test-retest variability of topography? There is test-retest variability in topography as well. It is higher in keratoconus than in normal patients. And when we looked at between the pentacam and Galilei and the OBSCAN, it seems that the pentacam and the Galilei have the least variability. Variability is about 0.4 test-retest for the same patient at different times. So typically anything more than that, 2 standard deviations more than that, is what you should consider as progression. So the younger the patient, so like in this case, children, the more likely even minimal progression is going to push us towards cross-linking as compared to somebody who's older. But having said that, our protocol is any child below 16 years of age, if they have evidence of keratoconus on topography, we tend to cross-link at the first visit. We don't not wait for progression because of several reasons. I think the main reason is that time that they are at risk for progression for this age group is much longer than when you have somebody who presents to you older. And that's the reason why anybody who has topography proven keratoconus at the first visit, I would cross-link at the first visit.
That's really great. I think you have made it very clear that refraction, you don't want to rely too much on in keratoconus per se, and topography change, even minimum change, if it's less than 16 years, you can straight away go ahead with cross-linking. Later on, you would like to document it, and preferably in topography or tomography. So I think that again, this message is very clear. So do you feel, Praveen, that we still don't have a very consensus on what exactly the progression is, and there's a need for another study or maybe some collaborative effort? So do you feel so? There's still a gray zone?
Yeah, absolutely. Because there have been several instances where patients have come in and said that, look, I'm seeing more distortion in my vision, and I think I progressed, so cross-link me. But on topography, we don't find evidence of progression. So I don't think we still have the holy grail of how to evaluate progression, but I still think at this point, it is probably topography. Not even tomography, I still think it's topography that is the best tool to evaluate progression.
Okay, great. Again, that's again a very important point, that you want to ensure that anterior surface is what you want to look at to make a decision in those cases which are borderline and you are not very sure about. So thanks so much, Praveen, for making it so clear for us. So the next question is, how does protocol differ from adults? So Dr. Namta Sharma, when you advise or perform cross-linking in children, is the protocol different, and how's the anesthesia requirements? Before you go ahead, I'll just show you what people have said. So they have said that they have equal numbers. So people have 49% have used Dresden protocol, and 45% say they use accelerated cross-linking in children. And for less than 10 years, the people who are 40% use general anesthesia, and again the same percentage use IV sedation. We also requested Dr. Shalini from Narayan Netralaya. She's an anesthetist.
Hello, I'm Dr. Shalini, anesthesiologist at Narayan Netralaya, and I would like to take this opportunity to speak a few words on sedation as an anesthetic modality for collagen cross-linking. The main anesthetic goal in such patients is maintaining immobility throughout the procedure, because thankfully the intraprocedural pain is almost nil and the discomfort can be easily managed with topical local anesthetic drops. So there are few patients in whom the lack of cooperation is either obvious or anticipated. This includes children in the age group of 5 to 12 years, children with special needs, and adults with special needs. So in all patients with whom a verbal communication, a meaningful verbal communication can be achieved, it can be done under topical anesthesia. For the others, we can either use sedation or general anesthesia. In our center, we use sedation in all such patients who require pharmacological measures to maintain immobility. We do a very careful patient selection and preoperative assessment, as well as planning in terms of maintaining a preoperative fasting of 6 hours and applying EMLA cream on the dorsum of their hands an hour prior to the procedure to provide painless intravenous line insertion. As well as there should be a plan in place to manage sedation failure as well as excessive sedation, and the continuous presence of the anesthesiologist inside the OT throughout the procedure is a must. There are several routes available: oral, intranasal, as well as intravenous routes of sedation. The oral route is simple, easy, but very poor bioavailability, and the sedation outcomes are not always reliable. Among the intranasal drugs available for the intranasal route, the dexmedetomidine provides good and reliable sedation, but needs to be administered half an hour before, and sometimes a second dose may need to be administered if satisfactory sedation levels are not achieved. The intravenous route is the easiest, safest, and most reliable, and the drug dose also can be easily titrated to the expected outcome, whether we want mild sedation and only anxiolysis or deeper levels of sedation. Several drugs are available and all of them are good. We could use intermittent boluses of midazolam with or without fentanyl, or sedative dose of propofol as an infusion, or intravenous dexmedetomidine as an infusion. So the take-home message is that sedation is a good anesthetic in collagen cross-linking, and one should try.
Great. So, which means that if you don't have it's not necessary to have GA only. Dr. Namta Sharma, so what is the protocol? Charuta said accelerated protocol, accelerated cross-linking. In the survey, we found 50% want Dresden also. What is your take on both these points?
So, as far as anesthesia is concerned, I think I'm glad that IV and sedation was covered, because at our center, we don't do too much of IV sedation. We either rely on general anesthesia for all those patients who can't cooperate, or we do with topical anesthesia. So, of course, when you give topical anesthesia in children, you have to keep talking to the patients and keep ensuring that, they are looking at the UV radiation and their fixation is not wandering. The general anesthesia in older children can also be used. We've used in a couple of them with the neck problem. One of them had a neck problem, and two of them one was Down syndrome and the other had a cardiology problem as well. So as far as us, and we've done this study, we have about, I mean, we published this also, and the part 2 of that is also going to be published soon on 116 eyes. So I think in pediatric eyes, and the question was whether it is safe or not. So collagen cross-linking is safe as far as the procedure is concerned. We never do bilateral simultaneous collagen cross-linking. It is always one eye followed by the other. Threshold for doing collagen cross-linking is really very low, because progression, I think, is really variable. There was a systematic analysis which was just published last month in Cornea, and some people take Kmax, some take Kmin, some take average K. So there is no consensus on that. And Kmax, to my mind, is a poor determinator because it does not measure the posterior cornea and it does not measure the epithelial thickness. So the way we do it is we do a sequential collagen cross-linking under general anesthesia if the cooperation is poor, under topical anesthesia if the cooperation is fine. And although in that cohort we did accelerated collagen cross-linking, and I think that is what is recommended for children, but I do feel, and we are continuing this study, I do feel, and it could be purely anecdotal, that when you do accelerated collagen cross-linking, you need to repeat the procedure, again. Retreatments are more if you do accelerated collagen cross-linking as opposed to conventional cross-linking in children, because eventually children would require retreatment because of nothing but because of the fact that the collagen turnover is 7 to 8 years only. So that is what I feel, and I think when we complete that study, we would be able to come out with answers thereof. But in all those children where we had done all those, in fact, all those repeat collagen cross-linking, which we had done in cases of children from that cohort and otherwise also had undergone accelerated collagen cross-linking, most of them, almost 90% of them, as opposed to conventional. So I am likely to think and likely to believe in future that wherever possible and the cooperation allows, err on the side of conventional collagen cross-linking rather than accelerated collagen cross-linking, although the time that you do it for is much shorter as compared to the conventional cross-linking technique.
Great, thanks so much. So one thing is clear, that IV sedation, you can go ahead, children doing cross-linking in children is not that difficult, can be done. Conventional cross-linking definitely works. Accelerated, still, there are many articles also, as you said, and there are some more researches going on. So basically why we are discussing it is we want to ensure that our cross-linking is effective. We don't have to do a cross-linking. As I said, the earliest age people have done cross-linking is 5 years or 4 years. So do we ever need to do a repeat CXL also? And what is your take on this, Dr. Rao? Before you speak, I request Darshana to share with us what is there in the literature.
Yes, sir. There is very little literature available on this topic. There is one study named Progression of Pediatric Keratoconus After Cross-Linking, a systematic review and a pooled analysis published in Cornea 2021. They studied 2078 eyes and they found out that the mean pooled progression rate after epi of CXL was around 9.9%. So this was the only study which showed the percentage. A recent report from Mesote et al., which was published in 2018, suggested that the CXL procedure in children may be more prone to needing retreatments with a 10-year progression rate of 24% compared with 5 to 6% in adults. So the estimated collagen turnover, as Namrata ma'am already said, was around 6 to 7 years.
So Dr. Rao, can you just solve this puzzle for us?
I'm not sure if I can, but thank you for having me on this program, and congrats on the format. I think it's very nice. I just put it in as a slide. Getting old, I forget things. So my experience is basically in the last 15 years or so, it's a little over 1,000 cross-linkings that we've done. I've had to retreat 4 patients. This doesn't give you any exact numbers because this does not include some of these people who had cross-linking and then have gone on to have corneal surgery for various reasons. They just lost interest in wearing lenses. Sometimes they came late after the cross-linking. So by then they'd already progressed beyond the point where I could cross-link them again. And some of them peculiarly had central corneal melts. There have been 4 patients so far who had central corneal melts about 8 or 9 years after the cross-linking with no apparent triggering events. So And again, the follow-up in a private practice sometimes it's not very rigorous. So these are just gross numbers, 4 times in the last 1,000 treatments that I have done. What are the indications for treating them? Basically, again, all the points were highlighted previously as well. So I look at both the quality and the quantity of the best spectacle corrected vision that the patient has, if there's a deterioration in that. We look at the topographic change in the maximal keratometry readings, look at the pachymetric thinning, and the increase in refractive astigmatism. It was already mentioned that in children, myopia per se need not be used as a guide because anyway the eye is growing. But if all of these seem to be coming together, then I would put that as a point and then go ahead and treat. Having said that, out of the 4, 3 of them were less than 15 years of age when they had the first cross-linking. One of them was 18. The 18-year-old chap had a mother who had pellucid marginal degeneration. She had cross-linking as well. Now, basically, before I retreat, I look at the pachy again. I want to respect the corneal thickness levels, and the specular assessment is done because I've already cross-linked them once. I proceed with my standard treatment, which currently is accelerated cross-linking, which is epi off. And out of the 4 people that we treated, 3 of them stabilized. These were the children. The 18-year-old chap who had it done 3 years later, he passed away, unfortunately, in a road traffic accident 1 year after that, but till he passed away, he was stable as well 1 year after the retreatment. So this is my limited experience with the retreatments.
So Dr. Rao, so we don't see much of recurrence if we do it in teenager or 20 years, because after 30 years journey, the cornea tends to get naturally cross-linked. But here the collagen turnover time is 6 to 7 years. So is it that when a child comes to us, so do we need to tell them that, see, you might need a repeat CXL because after 7 years, there will be the original collagen that will come up?
It's possible. I think, like I said, the ones that we have had to retreat are the younger ones. So these are the people who present very early on. They often have allergic eye disease. So they possibly have a more severe variant in terms of that's why it presents so early. The others, they present in their late teens or early 20s. So probably some amount of natural cross-linking is already occurring and you're aiding that with your procedure. So I think there's nothing wrong in telling the parents that we're doing the best we can for the child at this point in time to stop them from going into a corneal transplant. And we will see what happens 6 years, 7 years, 8 years. We follow them up. And if required, at that stage, if something is worsening, we will offer whatever is needed at that point in time. So I think you could mention that as a corollary.
Okay, so I think then here again, there is a possibility of CXL, although not very common, and specifically in CXL, we need to just keep that thing in mind. So the last question is, as we saw that this child had 6/9 vision. Suppose you have to do a contact lens fitting in children. Is it different from adults? How it is, and what are the challenges? For this, I invite Preetam Kumar from LVPI. What are your thought process? And before you tell us, so this survey tell us that around 50, so 30% of respondents always do contact lens trial before cross-linking because they want to know the visual potential. 50% said sometimes, only 18% says that they never do a contact lens trial. Maybe the patient already has good visual acuity. So over to you, Preetam. Can you just share a few pearls with the cornea specialist here, that what are the things that will be different in contact lens fitting in kids?
Hi, thank you, Dr. Vikas. There are 2 things that I actually wanted to talk about here. One is the profile of the patients that I see usually in the clinic, and at this point, the profile that we are seeing, mostly they are referred to the contact lens clinic for a trial after 10 years or above. However, if the question is solely that at what age, what is an ideal age where we can actually dispense these RGP contact lenses, let's talk about only corneal lenses for the moment, then I would say we do see other type of cases as well, and we start dispensing them 4 years onward. So if at all we want to dispense a lens even less than 10 years, that then also it is absolutely safe to use. And in fact, counterintuitively, these kids are they get adapted to these RGP lenses much faster because they have a little thicker tear volume. So that's what we have seen so far. Another thing, this is more related to your fitting of contact lenses, the way we fit these contact lenses. Typically for adults, we try to keep a little touch in the center of the cornea, and that sort of gives us better visual acuity, visual outcome. So now for these kids, as we are discussing here, that most of them will be referred post collagen cross-linking. So we are a little careful about how do we go about fitting this lens, and especially we try to see and avoid any touch in the center in terms of corneal contact lenses. And just to make a note that at a very young age, and what we have given for scleral contact lenses, that is something that we are talking about more and more in different forums now. Scleral contact lenses is a very good option, and we are giving it as giving this as young as 8 or 10 years of age. So this is also coming up as a very good option, alternative for these patients. Yeah.
Great. Thanks so much. So I think the message is, what you want to say is that scleral lenses may be more comfortable for the children. And another thing which I understand is if there is a child, so it's better to take help of a specialist who has some experience in it, so that we ensure that there is no issues with the kids. Thanks so much, Preetham, for your comments. And before we wind up this case, everybody has talked about eye rubbing. So in the survey, we found that 20 to 25% of the respondents found that there was eye rubbing is pretty significant. And for the same, there was a small video created exclusively for this meeting. So the basic idea is what kind of eye rubbing can cause issues. This knuckle rubbing or the circular motion is pretty important. So you might want to ask your patient that how do you actually rubs. But there is enough evidence also that rubbing is directly related with keratoconus. So I thank Dr. Himanshu for creating this video for us. So with this, we come to the end of case 1, and I hope that the questions were clear to some extent. With this, I invite the moderator for the next case, Dr. Purvasha, to take up from here. Over to you, Purvasha.
Thank you so much, and thank you, Dr. Vikas, for this opportunity. So I'll just start sharing my screen. Right. Good morning, everyone, and welcome to our next case, where we shall explore the beauty and the beast and put their pulse together. Right. So for the role play for this case, I would like to invite Dr. Vibha, our cornea fellow, as patient. The general ophthalmologist will be played by Dr. Devapriya, our cornea specialist at LGI Institute. Dr. Sonia Kothari would be the cornea playing herself as a specialist, and she's from Bombay City Eye Institute, Mumbai, and I shall be moderating the case. So I invite the team to take over the case and to take you through the case.
Thank you, Dr. Purvasha. So, good morning, Dr. Sonia, and thank you so much for your for consenting to give your valuable opinion on this patient. So, I have this 34-year-old lady who has presented to me with dimness of vision more for the last 3 years. She has been using her glasses since 15 years, but she noticed a frequent change of the numbers since the last 2 years. She has polycystic ovarian disease and she's hypothyroid, for which she's receiving treatment. She's been married for 3 years, but unfortunately has 2 miscarriages. When we did her refraction, her uncorrected vision was 612 in the right eye and is 3/60 in the left. And her with spectacle correction in the right eye, she's improving to 6/6 with a -2 cylinder at 80, and in the left eye, we can only improve her to 6/18 with a -10 sphere and a -4 cylinder at 140. Her anterior segment examination is essentially normal. Her fundus is normal. The intraocular pressures are within normal limits. So when we have a pentacam, so we went ahead and did it. And what I can understand from this map is the K1 and the K2, they seem pretty normal, 40.7 and 41.8. I'm getting a thinnest location of 492 in the cornea and a Kmax of 42. And these are the bad maps, ma'am, which seem normal to me. And for the left eye, ma'am, this seems a steep cornea. I'm getting a K1 of 51.6 and a K2 of 54 with a Kmax of close to 56. And it's thinner than the right eye also, it's 417. And when I look at the bad maps, again, I can see that all those red areas in the difference maps. So because there was a difference in the refraction, gross difference in the left and the right eye, we did a biometry mainly to see her action length, but they were similar in the two eyes now. So if Dr. Sonia could just help me with the diagnosis and the plan of management in this patient.
Good morning, Dr. Debapriya. Hi, Purvasha and everybody. It's a very interesting case, where we are seeing that one eye has progressed significantly, whereas the right eye is almost normal. So definitely in the left eye, there is a clear evidence of keratoconus, and the right eye, the pachymetry is good. There is no clear ectasia, and the inferior superior asymmetry is also not there. So right eye, as of now, I would like to just observe closely and maybe, do a close follow-up, considering that the other eye has really worsened quite significantly. And every 3 monthly, I would like to observe the right eye and see if there is any progression. And in case I see any or observe any sign of progression, I would like to do cross-linking very soon in the right eye. The left eye, there is a significant ectasia. There is a significant, corneal thinning, which is also there when we compare to the other eye. But considering her age, that she is 34 years and in the childbearing age, I would like to ask, if there is a history of pregnancy. So is your patient pregnant, Dr. Debapriya, or is she planning her pregnancy very soon or something?
So Dr. Sonia, she's quite anxious. So I have her here with me. Vibha, you can ask your questions to our cornea specialist here.
Yes, good morning, ma'am. I had an history of 2 miscarriages, but now as my vision is deteriorating so much, so I just wanted to consult about I was more concerned about left eye vision. And currently I'm not pregnant, but I'm planning my pregnancy.
So, I mean, right now, with your contact lenses also, as I understand, you are not comfortable. So,
I cannot wear my contact.
What is the difficulty, Dr. Vibha, that you're experiencing with the contact lenses? Like, are you finding it painful, or is your eye becoming red after wearing it?
Yes, ma'am. I'm just scared of contact lens. I'm not comfortable wearing that. Also, one of my siblings had an infection with the contact lens wear. So I'm very scared and I don't want to use contact lenses.
So is it more of a fear or the intolerance to the contact lenses that you are experiencing?
Yes, ma'am, more of a fear. I just don't want to use them.
Mm-hmm. So maybe, for the left eye vision, we can, after improving your ocular surface, giving you good lubricants, considering that you are having thyroid as well as PCOD complaints, improve your tear film, and give you a proper training in using the contact lens. Also, I would like to check the fitting of the contact lens, whether it is tight or whether there is an edge lift or the feather touch that we are trying to achieve with the contact lens, and maybe try different type of contact lens from the vision point of view. Now that is from the vision rehabilitation point of view, but for stopping the progression, I would definitely consider doing a cross-linking even for the left eye using a hypotonic riboflavin, because her corneal pachy is, the minimum is around 415, 417 in the left eye. And I think with the epi-off, I should be able to do cross-linking with a dextran-free riboflavin in her left eye.
Also, I would like to mention that I am also on hormone therapy, some hormone replacement therapy also for PCOD.
She's taking hormonal pills, doctor, for PCOD.
Yeah, so I think that we have to do it in consultation with her endocrinologist and the gynecologist, making sure that our hormones are very well regulated, because we cannot plan a corneal surgical procedure or any procedure if our hormones are going haywire. So that is a priority in her case particularly. So I think that's how I would approach her, like wait for right eye as of now and keep observing closely. And for the left eye, I may think of an early cross-linking with a hypotonic riboflavin.
So ma'am, will my vision be normal after the procedure?
So cross-linking, as you know, everybody, as we all know, the vision may not be, will really not improve after the cross-linking is not done to improve your vision. It is done just to prevent the progression from happening. In fact, for the initial, 4 to 6 weeks, we may expect the vision to go down. But eventually, most of the time, we do see that the vision comes back to the pre-C3R level, or it may be a line or two less than that also. We do expect a change in the refraction number after cross-linking every time that we do. And with your case, with the hormones therapy going on, we may expect, there are some uncertainties which are involved that we have to be prepared for. Yeah.
Okay, so when can I plan my pregnancy after the procedure?
I think after cross-linking, even 1 month, 2 months down the line, you can plan pregnancy, because it will not have a long-term effect once the healing is achieved. Once we are sure we are not going to give you any post-op, steroids or antibiotic or anything, you can go ahead and plan your pregnancy. I don't think it should be a problem.
Okay. Thank you so much, ma'am.
Thank you so much, Dr. Sonia, for helping me out.
Thank you, Dr. Devapriya. Thank you, Dr. Vibha. Urvasha, you're on mute.
Thank you so much, everyone, for this wonderful role play. So here we have this 34-year-old young lady who is kind of in a case where there is hormonal issues in the form of polycystic ovarian disease, a hypothyroid state, and who is looking forward to start her reproductive journey. But again, she has developed this keratoconus. She's not able to tolerate contact lenses. So basically, she has many questions in her mind, wherein when will her vision return to normal? Can she continue with her hormone therapy or pills? And when can she be pregnant again? So before we move on to delve deeper into this case discussion, let us just quickly go through a quick recap of our knowledge of MBBS days as to how exactly do these hormones go about, or what are the changes actually happening during pregnancy. Over to you,
So this is a graph that depicts basically the hormonal levels in the 3 trimesters, although we have these trimesters depicted by these vertical lines. So the female hormones, essentially in blue and orange, they rise as expected during the 3 trimesters, with a spike in the 3rd trimester and a sharp dip after delivery. Progesterone, which is in green, that shows a more sedate increase, and then again it dips after delivery. And testosterone stays more or less constant throughout the 3 trimesters.
Right. And let's even find out what exactly are the changes during polycystic ovarian disease, and what do you mean by HRT?
So what, as ophthalmologists, we need to know in polycystic ovarian disease is the hormones that we are mainly concerned with. Estrogen surprisingly stays more or less normal in polycystic ovarian disease. It's a luteinizing hormone and follicle stimulating hormone that goes haywire. And testosterone increases and prolactin also increases. As for HRT, what essentially is what they're trying to do is essentially regularize or normalize the cycle or give hormones from outside, either a mixture of estrogen and progesterone or sometimes with androgen added in a cyclical manner so that it replicates the normal body cycle.
So thank you for this quick recap. And we now know that there are a lot of hormone surges during pregnancy, and PCOD is basically a hyperandrogenic state. And there are a variety of HRT that are available. So let's move on to the survey results that we have found regarding association of keratoconus with hormonal changes. So very few, that is less than 10%, feel that there might not be an association, and majority of us do feel that there is an association. So before we ask our beloved Dr. Srinivas sir about the association between hormonal changes and pregnancy and keratoconus, whether it's a fact or fad, let us quickly go through what literature has to say. And maybe I can just present what you found.
So we are essentially entering a kind of gray zone here. Physiologically, it is known in multiple studies that there are some topographical changes in pregnancy, curvature increases, there are changes in Kmax, and there has also been reported the presence of estrogen, progesterone, and androgen receptors. Next. However, healthy corneas, in some few studies carried out, they do not show consistent effect on topographic parameters or biomechanical properties. But in a head-to-head study carried out by Nadiran et al., their group, 11 pregnant patients and 11 healthy volunteers, they showed that there is a severity of KC increase during the pregnancy and post-pregnancy periods. So basically, other than estrogen and progesterone, you also have other hormones that are playing a role, like dehydroepiandrosterone, the hypothyroid state. And essentially what we see from the entire thing is severity of keratoconus is increasing, especially in the second and third trimester. And it is not just related to estrogen, but also thyroid stimulating hormone, the DHEA, and other hormones like prolactin induced proteins. So this is another study carried out actually on experimental study by this Pearl group on porcine corneas. So basically what we get from the study is the biomechanical parameters changed more in corneas that were incubated in estradiol culture medium. Basically, estradiol changed the Young's modulus by quite a significant number. So here we have lots and lots, quite some anecdotal reports essentially. There have been no proper studies carried out per se. So the first reported and published case was by Efficacy et al. From the Elsa Institute, where they had their patient progressing 2 years after LASIK when she underwent her first pregnancy. And then they cross-linked her. We have reports from India by Dr. Padmanabhan et al. And we have a report from LV Prasad, 12 patients, 20 eyes of 12 patients, where there was post-LASIK ectasia in the majority of the group, and then some virgin eyes had developed keratoconus or keratoconus progressed during pregnancy. And basically, what we can see with all these studies is that keratoconus progresses during pregnancy, but what we have mainly with us are anecdotal case reports and a few case series. And I just wanted to show this case here, a very interesting case report where this patient was actually 51 years old. And she had a previously stable keratoconus, and she has actually progressed with her HRT at 51 years of age. She had to be cross-linked at that age.
So, as we found, there's so much of hormonal changes that are going on, and they're causing changes in corneal curvature, topographic changes, and biomechanical changes. But literature is still very scant. So, Dr. Rao sir, do you think that your management changes of such patients with keratoconus based on the hormonal status of the patient? Over to you, sir.
Thank you, Purusha. I think basically this meeting and this question had me thinking, because I know about this association. I've been managing patients, but I've really not given that much thought to it. So when I thought about it after you asked me the questions, I think I have seen worsening of cones in some of the patients I've had after their pregnancy. I've had patients who had a very stable laser vision correction come back with some shifts in their refraction after pregnancy. And I've seen post-LASIK ectasia and previously stable eyes after pregnancy. Again, this is just anecdotal based on the experience in my practice. So it does seem to be present, but it also seems to be uncommon, and the nature of the interaction is not very clear. I'm sure a lot of keratoconic women have pregnancy and not all of them get worse after that. And interestingly, the PCOD that we're talking about actually causes an increase in the corneal pachymetry. So that again is at odds with what we're seeing about the keratoconus progressing, and hormonal replacement treatment has often been blamed. So what I've been doing is that when I see these patients, I ask them to get their hormonal disorder addressed. That's not in my purview, but I get them to work with their OBGYN and get that fixed. And I will treat the ectasia that they have on its own merits, unless they're pregnant. And if they're pregnant, then I choose to defer treating them until the delivery is over. But if otherwise, if the cone by itself needs treatment, I will not delay the treatment. I will go ahead and ask them to continue to get their PCOD or whatever it is managed appropriately. And the question that was asked about, I had a worsening during this pregnancy, you managed it for me, I need to go ahead and have a second baby. What do? I tell them I don't have an answer. I don't think there's enough evidence to tell them go ahead with the pregnancy or not to have. I don't think we can play God there. So I just tell them this is the data. There is a possibility that it may worsen even after your second pregnancy. If it does, we must be prepared to treat it. And that's the best answer I have at this point in time.
Thank you so much, sir, for summarizing it so well. Yes, as we've also found out after going through literature, there are a lot of gray zones, and what we take for granted is not exactly published anywhere. So next we would like to present the survey results here, where we asked our audience whether they would be comfortable doing a cross-linking in a pregnant lady with a progressive keratoconus. So almost more than 90 to 85% of them were not sure or would not go ahead with it. So that is significant. And here again, this is a topic where we are not sure and we don't have any clear idea what is going on. So, and before we would be interested in knowing Dr. Vinay Agarwal's opinion about this, we wish to bring ahead what we searched in literature about this, about pregnancy during CXL during pregnancy.
So again, here we are into murky waters. So pregnant and lactating patients were excluded from all FDA clinical trials in the approval process, and no published studies or reports currently address the matter. Not only is the safety of the procedure in this patient population unknown, but its effectiveness. We were having a discussion in the morning. I think there was a discussion in the Cornea interest group, and Dr. Mascati was talking about the category C medications. So basically, these are medications which may not be used, no animal studies carried out, we don't know the effect on the fetus. And cross-linking is usually avoided in pregnancy, keeping in mind that there may be possibility of complications that may require systemic therapy or additional procedures.
And also that despite this, the hormonal changes might lead to progression of the ectasia.
Yes, we discussed that. Yes.
Yeah. So Dr. Vinay, do you feel it is safe to perform cross-linking even during pregnancy if the vision is seen to be deteriorating after because of keratoconus progression? And will the cornea stabilize or remain stable during future pregnancies?
I think both these answers would be linked to what Dr. Srinivas had mentioned earlier. The data with us is absolutely inadequate, though whatever little or whatever few patients I have had, my experience tends to move on both sides. I have had patients, female patients with keratoconus who've gone CXL successfully without any changes. And do have patients wherein there has been progression. So Juliet out, because I don't think we yet understand the intricacies of the collagen and understand what is actually being achieved with CXL. So would I allow them to go for pregnancy? As I said, I'm not the authority on it, but yes, a pregnancy can move it either way. As far as doing CXL in a patient with pregnancy is concerned, I don't think I would do it. And not because the ultraviolet light on the eye is going to be an issue, but because the hormonal status at given points in pregnancy is going to be different. So the impact of a CXL during a pregnancy is not going to be very controlled. So I would rather wait for the post-pregnancy phase, a stabilization in the hormonal scenario, and then consider a CXL. even if there is progression during pregnancy.
That's right. So during pregnancy, it's not advisable.
I would not do so.
Right. So now once Dr. Vinay has decided that a CXL is important for a patient, we need to know if the hormonal treatment can go on for our patient. And also how soon can she then conceive because she wants to start her family life. So before we invite our favorite Dr. Namrata Sharma Madam for her opinion, we present a quick survey or a quick search of what is published.
So very few reports on whether the hormonal treatment can go on. Anecdotal case studies essentially. This is Hafizi's group reporting a patient who developed iatrogenic keratoconus when she became pregnant 2 years after her LASIK. She was cross-linked after she delivered, 2 years after she delivered. However, she had her second pregnancy at an unspecified period after her cross-linking, and her right eye progressed despite the cross-linking in her second pregnancy. So basically with that hormonal change it did. And this is another case series of patients, 24 eyes of 19 patients. They had accelerated cross-linking. The mean time between when they became pregnant and cross-linking was around a year and a half. And they were followed up after their delivery for around 2.5 years. So what they basically saw that the Kmax had flattened during cross-linking. However, it increased again during pregnancy and then decreased back to the pre-pregnancy level after pregnancy. And there are other anecdotal case reports where they have been shown to either have high drops during pregnancy, even after they have been cross-linked.
So Dr. Namrata Sharma had to leave. So Vasha, can you request Dr. Praveen to answer that question?
Right. So since with literature showing hardly any consensus, would you consider hormonal therapy to go on after the patient has been cross-linked, and when is the earliest that she can be advised to conceive so as to not make her Keratoconus progression go ahead further, or with the possibility of future progression of Keratoconus? Dr. Praveen, if you could please answer for us.
I'll probably address this question a little differently, not from the ophthalmologist point of view, but I think there are two aspects to this. One aspect is the fact that when we speak about the relationship between fluctuating levels of hormones in the blood and potential effect on keratoconus, I think it is time that we actually dissect that a little more and focus on what hormones we're really talking about. Because I think, like you presented in literature, there are several suspects and several potential hormones that actually can be responsible, from gonadotropins to LH to prolactin-like hormones, and several mechanisms as well. And I think it is our responsibility to be able to actually judge that and study that, because nobody else is ever going to do that. So I think we should wait for something like that to actually happen, and not include all hormones that probably have an effect. That is one part. And I think the second part is, I think as ophthalmologists, several times we look only at the perspective of the eye. But again, if you look at the holistic perspective, and I think when you're looking at a young lady or a young family who's planning to actually have a family, lead a normal life, I think that is of abundantly greater importance than the progression of the keratoconus. I know we look at it from our perspective, and we can always give advice that, okay, I mean, be careful about having a second child or pregnancy. But I think that advice, like Dr. Rao said earlier, we really do not know the actual answer to that. So I think it's laying out the information and assisting them in taking a decision, with the understanding that there is a much bigger perspective behind cross-linking and keratoconus, and this is not the only one that we're addressing. I'm hoping that I answer that question, not directly, but potentially indirectly. But I think I feel strongly about that.
That's so true, Dr. Praveen, because it's not the right eye or the left eye for us. It's the entire patient that we're treating, as well as their families which are connected. So thank you so much for your opinion. And now that we've managed the case well, and we've done her CXL, her corneas have stabilized, but her problem still remains that her vision is yet to be rehabilitated. She's intolerant to contact lenses, does not want to wear them at all. So we would like to take your opinion, Dr. Praveen, as to how to go ahead with this. Would you consider in this kind of a patient who has a progressive keratoconus, has been cross-linked, but has a thin cornea, would you, has not been cross-linked yet, but has a thin cornea and is CL intolerant, would you like to do a DLK straight away? So what is your take on that?
Yeah, I think very pertinent and very logical question as well, because this is not an uncommon scenario. You do find several patients who present late with keratoconus that is quite advanced in one eye and one eye that is near normal, potentially because they've been seeing very well from the near normal eye. And we've found that patients who tend to have near normal vision in one eye, like this patient that you showed, their ability or their willingness to use contact lenses in the other eye is much lesser than in a patient who potentially has poor vision in both eyes because of keratoconus, just because of the fact that they can see well from one eye. And also when we talk about contact lenses, the role of contact lens in a patient who has one eye with very good vision is potentially limited, because it only is going to impact their performance in certain situations. And I think in this special subgroup of patients, my threshold for doing DALC would be very low. If they're not willing to try contact lenses or wear contact lenses, I would be happy suggesting DALC for them, because I think that probably provides a much more constant visual support in the other eye than the part-time visual support that you get with the contact lens, which I find they're very unlikely to use, like I said before, if they have good vision in one eye.
So do you think they would be willing to undergo a transplant at this stage when they are on hormonal therapy or something? Do you feel there would be resistance from their side to this? How would you go ahead counseling them about this?
I guess the timing of the procedure is something that you can always decide along with the patient. It's not that it is a procedure that needs to be done right away, or is it time bound like cross-linking. This is a decision about what is the next logical step. And the timing of the surgery, it can be any time whenever everything else is settled down and maybe her general health, everything else is more predictable.
So we give it in their hands to decide whether the eyes
timing
or the baby. Oh, right. Thank you so much for your valuable advice. And we go ahead with our next survey results. And this brings us to another modality of treatment. We asked about intacts or intracorneal ring segments, and the practice patterns were that 2/3 of the respondents were not doing intacts, but the rest of them, half of them, were divided between a combined procedure of intacts and CXL, and the rest of them were preferring a sequential procedure. So I would invite now Dr. Fogla's insights into this. So Dr. Fogla, do you think in a patient who has a thin cornea and who is CL intolerant, would you like to go ahead and do an intacts? How do you decide how to select the case, and a tip or two on how to visually rehabilitate them after intacts is done?
Well, my experience with the intracorneal ring segments is primarily with Intacs SK. There are other intracorneal rings such as Kera ring and the Ferrara ring, which are available. And these, the other rings give you a little bit more customization in terms of the arc length of the segment and the variability in thickness between one edge and the other edge. And a lot of people in South America, they are kind of very, they use it very frequently in their practice to manage keratoconus. But it's not a very frequent usage in my management options for keratoconus patients. But in the subset of patients where we have used it, we have been able to have satisfied patients with the intracorneal ring segment, the Intacs implantation. Primarily, I like to use it for mild to moderate keratoconus. I avoid using it for severe keratoconus, especially where the K reading is above about 57, 58 diopters. And also patients who have high myopia, therein if you do an Intacs, the patient's perception of vision improvement is purely related to improvement in unaided vision. You may be able to put in an intracorneal ring and reduce the astigmatism or the asymmetry. But if that does not translate to the patient seeing better unaided, often they don't relate the success what you define. For them, the treatment has not had any benefit. Now, in this case, where you have a patient, like Praveen rightly mentioned, that if a patient is seeing very well with one eye, very seldom, despite a good fit, their tolerance level to wearing a contact lens is not too great. So even in this case, if we were to go ahead and put a Rose-K lens instead of a scleral lens, which is a smaller lens, chances are the patient may still not be willing to wear it. She has high myopia, -4 diopters of astigmatism, and the cone is fairly central. So in this scenario, and her mid-peripheral thickness, corneal thickness is normal to have an intact SK segment being put in. If I had to choose an intracorneal ring segment before doing a DALC, because DALC is a great option, but if the patient says, okay, do you have anything else that you want to offer me? What I would have done is maybe I would have put symmetric rings in the cornea, which would have had like a flattening effect on the cornea, and it would still keep the cone central and reduce the corneal steepening. And after that, if it translates to an improvement in her best corrected visual acuity using spectacles, Toric ICL may be another option to reduce the asymmetry between the eyes and help her see better. But like I said, that there is no, the predictability with the intracorneal ring segment is not too great. So that I discuss with all my patients, and I tell them that your improvement can be anywhere from 25% to 85%, but before we put the ring, we will not be able to give you a definite answer as to what would be the final outcome. Since this is a reversible procedure, in case you have a patient who's not happy, you can go in and remove the ring segment and they would be back to where they started with. And with the advent of the femtosecond laser, performing the procedure is relatively simple compared to the manual technique that we used to use earlier. In your survey, you found that some people do cross-linking first, followed by the intracorneal rings. In my practice, I prefer to do the intracorneal rings first and then follow it up with cross-linking, and that somehow seems to give a better result. If I do a cross-linking first and then I put in my intacts, I don't see that flattening effect or the change what you see, because maybe the cornea is more rigid, so it does not translate to the same kind of outcome that I'm expecting. I don't do it simultaneously because intracorneal ring is basically an implant that you are putting in the cornea. And one of the biggest worry is that if you see an infiltrate in the cornea after you put in your intact implant, you will not be able to differentiate whether that's a sterile infiltrate or an infective infiltrate, because sterile infiltrates can occur after cross-linking as well. So why combine the two? I would do an intracorneal ring segment, and at a month later, when I see my patient, maybe I will recommend doing a cross-linking procedure.
This is excellent explanation. Thank you so much, Dr. Fogla, for clearing our doubts, and I hope this helps everyone. So, as we've seen, this patient or any other similar patients can actually be helped with different modalities and can still be, visually rehabilitated, and they can undergo their treatments and everything. And it is a multi-disciplinary approach. We have to take care of the systemic problems as well as the physician's opinion, the gynecologist's opinion alongside. So after this thorough case discussion, I thank the esteemed panel for their views, and I thank the team. And I invite Dr. Himanshu for the next case. So Dr. Himanshu, over to you.
Thank you, Purvasha. And here I go. We still have a very good morning only. We have not crossed the noon part. I'm happy about that. So this is the final case, and that's why we name it Final Destination. We have with us for role-playing Vishwa, who's going to be patient. Indrajot is going to be general ophthalmologist as well as literature reviewer. Dr. Akanksha Sinha has agreed to be cornea specialist, and I'm going to be your host. So going over to the case, over to you, Indrajot.
Thank you, sir. Good morning, Dr. Akanksha. I am stuck up with the case, sort of complicated, and I need your expert opinion for the same. Dr. Kanksha?
Hi, good morning.
How
Hi,
are you?
Can you hear me?
Yeah. Now I can hear you.
Hi.
So can I start with the case?
Yes.
So 53 years old female presented with complaints of blurring of vision, which was more since last 6 months. And the right eye blurring she complains since a longer time. She is a contact lens user, uses RGP lens. In right eye, the vision is not improving, so she has stopped using it. In the left eye, she has stopped using since last 3 days. There is no history of any active eye rubbing, no allergy, no trauma, no hormonal disturbance. She's wearing spectacles since high school, like long time back. And she's complaining of left eye irritation with contact lens recently and frequent falling off also. On examination, her visual acuity is 2/60 in the right eye with pinhole improving to 3/60 and not correcting with spectacles. In the left eye, it is 4/60 improving to 6/12 and with a correction of -11 and -6 at 125 degrees, 6/12 partial. A scleral contact lens trial was done and the right eye improved to 6/24 partial and the left eye 6/6 partial. Next slide, please. Slit lamp examination has shown both eyes thinning with Vogt striae and ectasia in the center with generalized thinning across the whole cornea. Both eyes also has an inferior corneal thinning typical from 5 to 9 o'clock in the right eye and 3 to 8 o'clock in the left eye with a beer belly appearance. There is also a vertical large band of thickened DM and poor endothelial specular reflection and vesicular type of lesions around the central band. She also has cataract, which is significant in the right eye and has 2 to 3 with PSC and left eye early changes. The fundus is tessellated and otherwise it's normal. Next, please. So we went ahead and did a pentacam for both the eyes. And as we can see, the right eye pentacam has an irregular surface with inferior steepening. The thinnest pachy being 364 micron, which is paracentral, and the steepest K being around 69 diopter, which is inferior in location. Clinically, we have suspected the inferior thinning. So we went ahead with the asocity and the right eye shows a peripheral thinning of around 277 pachy. The left eye pentacam also has an irregular surface with inferior steepening. The thinnest pachy being 347, again paracentral, and the steepest K being around 70 diopter, which is inferior in location. And even the asocity has a peripheral thinning around 265 pachy. We've done this optical biometry to see for the axial length, and right eye has an axial length of 29.93 and left eye 27. The right eye tomography shows a vertical band on the endothelium, and also the same area, Scheffler image shows high reflectivity on the endothelium. A slit lamp photo, as can be seen, there's a vertical band on the Descemet's membrane with a typical tram track appearance. The confocal image in the same area shows sharply demarcated excavations and dropout areas with tractions and fibrillar amorphous type material which is hyperreflective surrounding it. So Dr. Kanksha, ma'am, this is my case, and could you please give your opinion on diagnosis, how to manage, and the timeline required for this case? I have brought the patient along with me. If you need to ask any questions, please feel free.
Like to ask the patient, at what age did she realize that she has suboptimal vision, and when did she start using glasses or contact lens?
Ma'am, I started using glasses since my school days. I'm wearing it since my school days.
Okay. And right eye vision was always lesser as compared to left eye?
I felt so. I always tend to use my left eye.
Okay. And when did you start using contact lenses?
Somewhere in my late 20s.
Okay. Were you comfortable with contact lens? How was the comfort in your right eye with the contact lens?
No, ma'am,
Forget
I'm
about
not
the
at all.
improvement of vision at present.
No,
Not
ma'am, I'm not
comfortable
at
with
all
contact lens
comfortable.
at
It's
all.
so difficult. It keeps on falling. I'm not at all happy with it. I've even
In
stopped
both
wearing
eyes.
it. Yes, ma'am.
Okay. Did you any time have any history of like severe pain, watering, or whitening of the right eye which resolved?
No, ma'am.
Anything like this? No history. That's it.
No, ma'am.
Okay. Okay. So we have a 53-year-old female who has axial myopia, and there is a significant difference in axial length in both eyes with cataract, which is more in right eye. Can you please show the topography of the right eye? As you correctly mentioned that there is a significant steepening and there is a thinning of the cornea within 5 millimeter zone, and there is a correspondence in the elevation map also. We see the elevation of the thinnest point. So that is suggestive of keratoconus with the eccentric cone. But the slit lamp examination also revealed a typical beer belly appearance, and ASOCT has revealed significant thinning in the inferior part. So in both the eyes, so there is associated pellucid marginal degeneration also. And because the patient is contact lens intolerant, then that leaves with the surgical option in the right eye. So I will consider
Excuse me, ma'am.
in the right eye.
Just the scleral contact lens was tried and she was very fine with it. She was happy with it. In the clinic, I gave a trial. So she was very comfortable and happy with it.
In right eye also, the comfort was good in right eye. I'm not asking about the vision
but she
improvement,
improved.
but there is significant cataract.
Yeah, she was comfortable, but she was improving only up to 624 partial.
Okay, so if she's comfortable with right eye scleral contact lens, then I'll just go ahead with cataract surgery with a monofocal lens and followed by a scleral lens. That will be my plan for the right eye, if she's comfortable with scleral lenses. If she's contact lens intolerant, then we'll have to consider.
The patient is, yeah, please go ahead, Vishwa.
Ma'am, I wanted to ask, after operation, will my vision become normal in the right eye? Will it be almost like left eye?
See, the surgery will be done to stabilize the cornea, to provide tectonic stability, and after that you'll need cataract surgery, followed by probably a scleral lens. With that, we'll be able to give you vision, because you have a larger axial length also, probably that eye is amblyopic. It will not be as good as your left eye, but whatever best potential you have in that eye, that we'll be able to achieve with all these measures.
Ma'am, how much time will it take, and my vision will still be the same? Will my vision be same as in left? It will be good. Will it be good, ma'am? I'll be able to do things with my right eye.
See, ultimately, if you use your both eyes, will function binocularly. Your right eye is definitely weaker as compared to left eye. So it will not be same as left eye. That's what I'm trying to tell you. But we address all the issues which are present in your right eye. So we stabilize your cornea, then we do the cataract surgery, and then whatever potential your retina has, with the scleral lenses, we'll be able to see. Am I making myself clear?
Yes, ma'am. Thank you so much.
Excuse me, ma'am, I would like to ask, will any intervention in the right eye have an effect on the daily activities of the patient? I mean, will it help a lot? Like right now also she is 624 partial with the scleral lenses. So will this active intervention help, and what about the high myopia?
She has significant cataract in right eye. She has almost grade 3 cataract with the posterior subcapsular cataract, and she has noticed a recent onset of decrease in vision. So that could be explained by that. So a cataract surgery would definitely help improve the recent onset decrease in vision.
And can we consider DALK in this case for the right eye or triple procedure?
Yeah, if she's comfortable with contact lens, that will be the first option. But if she's contact lens intolerant, then a tuck-in DALK can be considered. But you have also mentioned that there was central DM scar. So that we have to see if it is affecting the visual axis, then maybe later a central, smaller, full thickness graft may be needed. But if it's not affecting the vision, it's in the paracentral area, then only a tuck-in DALK can help if she's contact lens intolerant.
Okay. And what about the left eye?
Left eye, you mentioned that she was using rigid contact lenses till 3 days ago. So I would advise her to stop contact lens use for 4 weeks, and then we'll repeat topography after 4 weeks. And she's very well tolerating contact lenses in that eye, and there is very less cataract. So I think like no active intervention, we just keep a watch. And considering age also, she's 50 plus, so there are less chances of progression.
So we'll go ahead with the right eye, and what the timeline, she'll recover vision, whatever, and then later on we'll give her lenses, right?
Yes, yes.
Okay. Over to you, Dr. Himanshu, sir.
Thank you both of you, and thank you, Dr. Akansha, for being here and helping us out. So here we have a case which is advanced keratoconus, pellucid marginal degeneration, and axial myopia, and along with that, to further complicate, right eye also has posterior polymorphous dystrophy. Now, I want to give a little more attention to the axial length part of it. Remember that when we have a difference of 2.5 millimeter between two eyes, where right eye is nearly 30 and left eye is around 27.5, there are very high likelihood that that eye might be amblyopic, and patient might be actually using the better eye, which is left eye, and that's what patient is doing. So intervention on the amblyopic eye may not be as useful for the day-to-day activity of the patient. That's one thing we have to remember. Also, role of axial length to bring out. Many times we fail to measure the axial length preoperatively, irrespective of whatever corneal transplant we are doing. Now think about it. If somebody has axial myopia, and if we do a corneal transplant, patient expects a visual improvement. But we know that immediately after the corneal transplant, whether it's a DALK or PKP, the axial myopia is going to get exposed. Now, in this case, right eye, if a patient has 30 millimeter axial length, maybe around nearly 20 diopter of axial myopia will get exposed when we just do a DALK or PKP. Now, if we do not tell this thing in advance to the patient that, you know what, it's going to take, and as Dr. Akansha was rightly explaining, that it's not immediately, it's going to take time, step by step. So this step, if we know in advance, we must tell patient that, you know what, your axial length is higher. We'll wait till the graphos junction becomes better, the sutures are out, and then we go for a visual rehabilitation procedure in terms of either early cataract or a phakic IOL, whatever suits us. So that's the importance of axial length, and which many times we fail to document, irrespective whether it's a keratoconus or any other thing. As some of the panelists have to go, I'm going to change the little bit sequence of discussion, and we're going to start with the cataract surgery in keratoconus. Now, this case had cataract, significant cataract, and it's not uncommon to have such kind of case scenario where we have cataract with the keratoconus. So I would like to bring in Dr. Srinivas Rao with his knowledge to guide us about cataract surgery in keratoconus. And before he takes over, I would request Indrajot to tell us something about keratoconus and what's there in the literature. So we will be starting with IOL power calculation. Indrajot, over to you.
Yes. So for the keratometry part to be used, we reviewed an article by Watson et al. Concluding actual K values to be used for mild to moderate cases, whereas standard K values are preferred for severe K-conus cases, as the use of actual values may result in large hyperopic error owing to the effective lens position. 2 other review articles suggest the same. Now coming to the IOL calculation formula to be used, a review done by Leela Ghyasan et al. Have concluded SRK2 formula is most accurate for mild Keratoconus cases. For moderate to severe cases, we have limited literature. There was a recent article by Camps et al. Having compared 4 formulas, and they have concluded most consistent results with Holiday 1 and SRK-T formula. However, SRK2 formula was not used in the study.
So over to you, Dr. Rao. Can you guide us in this subject?
Thank you, Himanshu. Basically, again, this got me thinking about this because this is not a problem that we come across all that frequently. We're more worried about the cone itself. The cataract follows the cone, and basically we don't deal with it as commonly. So apparently the current problems, like we saw from the brief literature review, are that the optical biometry tends to overestimate the keratometry readings in these people. And therefore, quite often we end up with a hyperopic postoperative error. And this degree of overestimation increases as the corneal steepening worsens. So basically in a study, they classified this as mild if it's less than 48, moderate if it's 48 to 55, and severe if the maximum K is greater than 55, and the worst errors occurred in these patients with severe cones. Why is it difficult? Basically because when we do a biometry value calculation, we do the keratometry, and in these patients, there are many problems. The first is we're taking the central 3 millimeters and we're using it to approximate the central keratometry. And we know in a cone that doesn't necessarily be true. The relationship between the anterior and the posterior corneal curvatures is very altered. And the separation between the anterior and the posterior curvatures is also altered, which means that when you use a refractive index of 1.3375 for your corneal keratometry conversions from the curvature, that goes wrong as well. The most important problem possibly is that these people have very deep anterior chambers, and therefore the effective lens position calculations become very altered because most of them use keratometry to measure this. And in this case, since this is wrong, this tends to be wrong as well. The third thing is there's a difficulty in measuring axial length itself, probably because of the visual axis due to the corneal distortions that are present. And finally, we are not sure which formulae to use because formulae make assumptions about these things, about keratometry, axial length, anterior chamber, and usually these are all correlated in most of the eyes. And in keratoconic eyes, this correlation is all disturbed, and therefore the IOL formulae also perform less well. So for me, basically, when I'm talking to my patients, I tell them that emmetropia is not the goal, like in a normal cataract surgery. That despite improved understanding, there is going to be a decrease in the refractive accuracy of the outcomes after the cataract surgery. And the goal here is basically to try and improve the unaided visual acuity. We're not really talking about spectacle independence and so on, like in a normal cataract. And I also tell them that despite everything that we are doing, if the power calculations go badly wrong, we may learn from that and then end up doing an IOL exchange. During the surgical planning itself, because these are corneas with very poor rigidity and these are basically eyes with poor rigidity, you may need to suture your clear corneal incisions. And if you're going to continue the patient on contact lenses, it's been suggested that you don't use a toric IOL during the surgery. Avoid a toric IOL if there's any possibility that you're going to go ahead with subsequent corneal surgery because then everything will change after that. And if you do use a toric IOL, consider a capsular tension ring to reduce the possibility of the IOL rotating. And this is important, particularly if the axial length of the patient is greater than 25 millimeters or if they have a larger white to white more than 12.5. These corneas are hyperprolate, and therefore we avoid the negative asphericity IOLs which we normally use in our day-to-day cataract surgery. Consider a traditional IOL with a positive or at least an IOL with a neutral asphericity here to avoid worsening this hyperprolate problem. And if you can just go to the next slide, thank you very much. So this is basically my practical guidelines. This is what I do in my patients. I first check if the keratoconus is stable. If it is not, I will stabilize it first. This is very unlikely because by the time they present to you for cataract surgery, they are in their 40s or 50s and they are basically stable keratoconus. So assuming that the keratoconus is stable, the next question is, did they have good quality of vision with their spectacles before the cataract developed? If the answer is yes, they were enjoying good spectacle corrected visual acuity, then I measure the K and I also use my Sirius tomographer to give me what is called a refractive equivalent K, which looks at the Gaussian optics. And between the two of this, I use the higher K value basically.
So I'm aiming for a slight myopia. I use the SRKT formula, and then if the astigmatism on the tomographic or topographic map matches what the patient is using in the spectacle, and if the topography shows a fairly regular astigmatism, I will consider a toric. And this is if the patient has good vision with spectacles. If the patient basically has poor vision and is already using contact lenses, the question is, do they want to continue using contact lenses after surgery? Many of them have had a lifetime of contact lens use and they continue to use it even after surgery. And if they say that they are willing to use it after surgery and their maximum K is less than 55, meaning mild to moderate, I use the same guidelines. If their maximum K is greater than 55, then I just use a standard K of 44 diopters and I use a lens that targets low myopia, because anything that's residual, they will just continue with their contact lenses as well. If they say that after cataract surgery, they would also like to discontinue contact lenses, so they're having problems with it, then we talk about the option of a DALF and follow that up 6 to 8 months later after suture removal with an IOL. So this long-winded talk, I'm sorry about that. But this was basically trying to give you some idea of the way I look at this particular problem in my patients. Thank you, Himanshu, for your patience.
Thank you, Dr. So I just want to bring you back in what Indrajot was showing, that a couple of articles and little larger studies, they showed that when the keratoconus was mild to moderate, they use the same K values as it was measured. And when it was advanced, they used the standard K. So is it related to that advanced K might be needing contact lens, or later on you might need them for a corneal transplant? Do you think that can be the reason, or?
I think that is the reason, because in a very advanced K, it's very unlikely that they have good vision with glasses. They almost always need a contact lens or corneal surgery. And most of our measures of keratometry in these advanced cases, when the K is above 55, tends to be very abnormal anyway. So all of our normal thinking and guidelines and rules that we use in our standard cataract patients, I think we first have to bundle them up and put them aside before we approach this question of lenses in keratoconus. If we approach these patients with those same yardsticks and guidelines, trying to aim for a plus or minus half a diopter error and 6/9 or better uncorrected vision, I think more than the patient, we will be disappointed most of the time.
True. I think it's very important what comes out from here, that you should know what you are looking at. Now, if you think that you're able to visually rehabilitate this patient with your contact lens, yes, do trust these K values, go for it. But later on, if you think that you still have to give contact lens to patient, then you will be sort of messing up entire thing by changing a lot of myopic issues, which you would have created. Thank you, Dr. Rao, and thank you for being with us. I know you had to.
Thank you very much.
Thank you. So we'll move forward from here, and the other part of the cataract surgery, as he touched upon it, Toric IOL. I would like to bring in Dr. Fogla here for the Toric IOL, and before he speaks, Indrajot will tell us a little bit about what is there in the literature. Indrajot.
A beautiful, concise algorithm given in an article by Arej et al. Suggests cases with good CDVA where manifest axis is equal to the topographic axis, toric IOLs may be considered. But when manifest axis is not equal to the topographic axis, monofocal IOL is preferred. For cases with low CDVA, regularization of cornea with intracorneal ring segments may be considered, followed by preferably a monofocal IOL. And later on, the toric ICL can be considered for residual error. 3 more articles have suggested the same, that toric IOL may be considered in cases with mild keratoconus, regular astigmatism, where manifest axis is equal to the topographic axis, and a good CDVA. And I think Dr. Rao has covered and he's applying it in practical also.
So before I go to Dr. Fogla, this is what the survey showed, that, well, looks like our surgeons are pretty enthusiastic surgeon, and almost nearly 80% of them would like to put a toric IOL. Dr. Fogla, over to you. What do you suggest in clinical pearls about the subject?
I think when you are talking about toric IOL, there are two things that we are talking about. One is the phakic toric IOL in young patients with keratoconus, and the other one is In relation to cataract surgery, would you?
This time I'm with you for cataract part. We will be coming back to you again with the toric IOL. So we'll keep the toric IOL discussion later on.
In relation to cataract surgery, I think the subject has been very covered in detail by Dr. Srinivas Rao, in the sense that if you have fairly regular astigmatism and it correlates with what the patient has been wearing in the spectacle correction, then definitely you can think about implanting a toric IOL, provided you don't foresee the patient undergoing a corneal surgery in future. Because if this patient is going to undergo a corneal surgery in future, then the toric IOL that you have initially placed in the eye will not perform. I have had patients with pellucid marginal corneal degeneration where the astigmatism is fairly regular in these eyes and the patient has had stable topography for several years. We have even performed customized toric IOLs in these eyes where the astigmatism is in the range of 12 to 14 diopters, and we have been able to give good outcomes to these patients. So I think it's important to understand whether, number one, whether your cornea in the pupil area is regular or not, the astigmatism, and choosing the right IOL, and explaining to the patient that in case a surgical intervention is required in future, then the IOL may need to be exchanged.
Thank you, Dr. Fogla. And that actually shows that though 80% of respondents would love to use toric IOL, yes, we can use it, but we should be careful in selected cases, and not every case of keratoconus should be treated with toric IOL. The other part of cataract surgery, I would like to bring in Dr. Praveen here, that before doing cataract surgery, do we need to tweak the cornea? Do we treat the cornea? Do we stabilize the cornea? And before Dr. Praveen comes up, I would request Indrajot again to enlighten us with anything which is there in the literature.
This is a study by Alfonso et al. In which sequential ICRS followed by cataract surgery with monofocal IOL was done 6 months later. And this has shown a predictable and good visual and refractive outcome in their cases. Next, please. A review done by Moshifara et al. Have depicted an algorithm which begins with stabilization of Keratoconus, as Dr. Rao has mentioned. If unstable, cross-linking is done, and further regularization, ICRS may be considered. And later on, depending on the severity of Keratoconus, we know like toric IOL or monofocal IOL can be considered with cataract surgery.
Thank you. Praveen, over to you. What do you suggest? Is there any role of regularizing these cornea in any ways, whether it's a topo-guided PRK, whether it's Intex, whether do they need to be cross-linked when you're planning any premium lenses like toric IOL or something? What is your take on that?
I think firstly, I think Dr. SKR potentially covered all aspects of what questions arise from here. And I think Dr. Akanksha Sinha as well spoke about her choice of what she would do. But from the specific perspective of this patient, typically when a patient with keratoconus comes in for cataract surgery, the practical issue there is the fact that this is a patient who's lived with the vision because of the keratoconus for at least 20, 30 years, and is coming to you mainly because of the cataract at this point of time. So I think the goal should still be to remove the cataract. And when you are taking care of the cataract, I guess there are two aspects. What do you need to make the cataract surgery more predictable and more easy? One, you already spoke about the lens calculations and the kind of lenses that you would use. So I won't repeat all of that. The other thing is during cataract surgery, I think also trying to use an RGP lens that the patient might have used in the past. That will help to actually see the intraocular structures a little better, will tend to help as well. So that is from the aspect of cataract surgery, not doing corneal surgery in patients who come to you with cataract and keratoconus. In this specific case, I think there are two other points that probably would like to allude to. One is the fact that this still falls under a moderate kind of keratoconus where the central irregularity doesn't seem to be remarkably high. So I would still expect that you would get a reasonably good keratometry and biometry reading, and you will get away with a reasonably good outcome when you do a cataract surgery with a spherical IOL. The second aspect, like you mentioned, if you want to do a corneal procedure here, the thickness is quite low. So ICRS is probably not going to cut it, because you will have to do a lot of regularization. Potentially, if you have to do a corneal procedure in this patient, it might be a DALC followed by a cataract surgery. But then again, if you do a DALC followed by suture removal, you are pushing back visual recovery by a couple of years by the time you remove all sutures and get a reliable K. So for all practical purposes, a cataract surgery in this patient probably is going to be the best bet.
Sure. So nice. Thank you, Praveen. You took up the part of the patient of this particular case, and that's really nice. Just carrying it forward, what Praveen was talking about, the surgery in eye which has better visual potential helps the patient. So even the surgery, early surgery in left eye in this patient can actually visually rehabilitate this patient by reducing the significant amount of axial myopia which this patient has. And remember, patient had all these problems recently. So an amblyopic eye, which is the right eye, which has poor endothelium, touching that eye would be possibly my later choice. Rather, I would touch the left eye or better eye, or at least give the scleral lens in left eye and do the visual rehabilitation. Thank you, Praveen, for eluding this thing quite nicely. Next, we will come to the more complicated surgery aspect of this case. As Dr. Praveen was talking about, that this case is not simple. You have pellucid, you have keratoconus, you have endothelial dysfunction, so many things. I would like to bring in Dr. Namrata Sharma here to guide us about such kind of case where you may need large diameter DALC. Now, if you have a cataract along with this, if you have endothelial dysfunction along with this thing, how do we handle this? Dr. Namrata, over to you. Are you there?
Yeah, so Himanshu, thank you. I think this is a complex case which has a pellucid, which has a keratoconus, and you can do a deep anterior lamellar keratoplasty. But when you do a deep anterior keratoplasty, which is going right up to the limbus or right up to the periphery, there are a lot of challenges, especially because you don't want to perforate it, right in the periphery, because if you have to convert, then it's going to be a very large graft. So Dr. Vikas Mittal had asked me to answer whether you can do a tuck-in DALC or not in such cases. And believe me, it's very difficult to do even tuck-in DALC in these cases. If I am doing a DALC in such a case, I would, less would be more, in the sense that I wouldn't want to see Descemet's membrane when I do a DALC in such a case. I would rather leave, stroma behind and then just use, just do the DALC to tectonically stabilize that area, especially in the periphery, and also pass sutures very carefully, especially in the periphery, where you are trying to tuck in that part. Tucking in DALC in pellucid, which is, very thinned out, is again going to be a challenge. Of course, you can do it. And if you do it, you do get good results. But it is going to be a challenge. And like I said, I don't want to see Descemet's membrane when I do DALC in this case. I would rather have some stromal fibers, very carefully make a pocket which is present in the periphery so that you don't perforate it, not with a crescent blade, but with a lamellar dissector, because crescent blades are much sharper than your routine, lamellar dissectors are. And then, like Dr. Praveen said, that after that, do a cataract surgery. And again, that cataract surgery is going to be very challenging because one, you are going to do it after doing a tuck-in DALC. Sutures have to be removed, topographies have to be stabilized, and then you have a compromised endothelium also at the top of that. So you have to explain to the patient that, we are going to do a cataract surgery, but then there could be problems post-operatively. So I think it's truly a tricky case, and a case which is going to be, requires follow-up. So you have to again tell the patient that you need to be coming up again and again and follow up the patient regularly. And it's going to be a while, maybe 18 months or 24 months before patient is going to get the best visual potential.
Thank you, Dr. Namrata. I mean, that summarized that I don't think it's a great case to combine cataract surgery with DALC, certainly not. as both of them said, that you stabilize the cornea first and later on take advantage of cataract surgery to possibly get a better spherical outcome, or if maybe, God knows, you can put a toric lens also, as Dr. Fogla was talking about earlier. So please remember, combining these two may not be a best idea. A large diameter graft, tuck-in graft, can have its own complications of significant rejection, glaucoma, and all those things. We would like to avoid it. In such kind of scenario, if at all there is endothelial dysfunction later on, we surely can combine later on the DSEC or DMAC, and which can possibly help us visual rehabilitation. Moving further, role of Ekikal, and Dr. Fogla was talking about it. He touched upon that, and we thought it's a separate subject, so let's take it as a separately. I would like to bring in Indrajot again to tell us about what's there in the literature, and then Dr. Fogla can take over.
A study by Kamia et al., in which toric ICL was done to correct the high myopic astigmatism with a 3 years follow-up, have shown a good visual outcome in mild and stable Keratoconus cases. No cross-linking was performed prior to ICL in this study. A study done by Antonios et al., in which toric ICL was done sequentially 6 months after cross-linking with a post-op follow-up of 2 years, also have found a good and stable visual outcome. However, if ICL is done at 6 months post-cross-linking, they have suggested a slight undercorrection due to the hyperopic shift induced later at 1 year and 2 years follow-up.
Thank you, Indrajot. Then before Dr. Fogla takes over, this is what a quite confusing picture what our attendees or our survey attendees had. People would like to do cross-linking. Somebody would want to wait for a year time, majority of them. Many of them would want to wait for 6 months. There's no consensus. So Dr. Fogla, can you enlighten us? How do we handle keratoconus cases for phakic IOL? When do we do we always do cross-linking, and how much do we wait? Over to you, Dr. Fogla.
Well, phakic IOL can be performed in mild to moderate keratoconus, specifically with eyes with central cones, where the power distribution within the pupillary area is fairly regular. You don't have too much of superior-inferior asymmetry. And these are a subset of patients where using spectacles, they can see 6/9 or better, and they are happy with that quality of vision. So that's my selection criteria. Besides that, anterior chamber depth is usually not a problem. They do have good endothelial cell counts. And majority of patients in our series, when we saw, these were patients who also in addition had high myopia as well. So they had power of 8 to 10 diopters or more. And when we performed the toric ICL in these eyes, we had a fairly good outcome. And we always tell the patient that since the ICL is a reversible procedure, so if you are unhappy with the visual outcome, there's always a possibility that we can explant the ICL. In terms of cross-linking procedure, when we did our cases, we ensured that we had a stable keratoconus as one of the selection criteria. So patients, if you perform cross-linking, I think you can safely do a toric ICL 3 to 6 months later, because the changes in keratometry, even after cross-linking, if you see, don't happen immediately. They will take somewhere between 12 to 18 months before you start seeing any flattening of the steep keratometry. So even if you wait, there is no defined time limit after cross-linking, how long you're going to wait before you get any changes in the keratometry. And even if the changes in keratometry do happen, they don't happen to a great extent. It's usually in the range of 1 to 2 diopters commonly, although you have rare cases where they have progressive flattening. But that's something you can tell your patient that if you're going to do it, and if there are any changes in the corneal curvature, they may need to have change in their glasses, or they may need further intervention for the same.
Yeah, thank you, Dr. Fogla. So what, in summary, he was talking about, we can't do phakic IOL in all the cases. Central cone is very important. We should also look at the stable keratoconus, whether it's naturally stable or whether we do with the cross-linking stability. if the cone is not centered, we may be able to alter the cornea using a topo-guided PRK and make it more regular, and then do a phakic IOL, which can have much better visual outcome. Also, sometimes, Dr. Fogla, the objective and subjective axis are very different. So on pentacam, when we see, or on any topography we see, we feel that this has to be access, and the optometrist would refuse to give that access, and no, the patient is not accepting, and the difference can be as high as 40 degree, 60 degree. How do we solve this thing in phakic IOL?
There is a lot of discrepancy between the refractive axis and the topographic axis. Maybe you need to take a step back and not proceed, because then you don't know which is the axis where you should be. Although clinically you should be choosing the refractive axis when you are placing the eye. And you rightly pointed out, a single segment intact placed for an inferior cone can make the cone central, and patient can then be subjected to doing a toric ICL. The topographic guided refractive correction can also be done even post toric ICL. If the patient has some refractive error and you want to go and do further refinement, it can be performed. And same is true for cross-linking as well. So if you were to do a toric ICL in a patient, and later on, if there are any changes that you want to do a cross-linking, I don't think having a toric ICL in the eye, stops you from performing a cross-linking procedure later on.
Thank you. That's so nice. And please remember that whenever we are looking at these cases, if there are advanced cases, sometimes you may falsely end up getting very decent anterior chamber depth because of the central ectasia. So pay attention to the peripheral anterior chamber depth before we plan the phakic IOL. Thank you. And we move forward.
One point, Himanshu,
yes, please.
In terms of doing toric ICL for keratoconus, we sometimes come across patients who have advanced keratoconus and their spectacle corrected visual acuity is only 624 or maybe 618 partial. Now these patients, if they undergo a toric ICL and then if they are not very happy and they come to us for a DALC procedure or a corneal surgery because they are not able to wear a contact lens, then it becomes a little problematic, because then you have to also remove the toric ICL from the eye as well. So unless you have a patient who has best spectacle corrected visual acuity of at least 6.9 or better, I don't think that doing a toric ICL would be a good idea, because it can complicate the subsequent management.
I think that's an excellent point. It holds true for most of the procedure or most of the things where we use subjective acceptance. When the vision is less than 612, the reliability of subjective acceptance, cylinder axis, extent of the cylinder sphere is questionable. So any procedure, whatever you have to do, where you have to depend on the subjective acceptance, be very careful when the best corrected vision is very low. Thank you, Dr. Fogla. The next part we will be talking about, now we had this case, 53-year-old female. Now 53-year, we assume that they do not progress and they are stable. So is that true? So I would like to bring in Dr. Vinay Agarwal here, and before he comes in, Indrajit will just enlighten briefly us with the literature.
Article by Fujimoto et al., in which the monitoring was done by using OCT, they have concluded the overall progression of 18%, beyond 30 years, 14%. And in advanced Keratoconus cases, 42% of progression, with 28% being more than 30 years of age. In another study, CLEC, which is the largest multicentric study, they have shown 31% of progression beyond the age of 30 years. A study by Gokul et al. Have shown 20% of progression beyond 30 years of age.
So, Dr. Vinay, this means that even later age, we just assume that beyond 30, there is no progression. Well, the literature has different idea. What do you think? When is the right time to stop the following up case? Or when is the time where we can be relaxed that, you know what, this is fine, it's not going to progress any further?
Himanshu, the answer there would be a little different again, because my personal belief is that keratoconus patients that we see in India behave differently from all the literature that we read, which is unfortunately from the Western origin. Most of these studies, as you will see, will stop after 30 years, or they're trying to say that 30 years is a time when most will see stabilization. I tend to disagree. We have a fairly large number of patients wherein we've seen progression beyond 30 years of age up to 40 years. So I usually insist that a regular follow-up be maintained at least till 40 years of age. It could be 4 monthly, 6 monthly, or annually, depending on how a given topography or a given findings are during the particular visit. But the other thing which I'm beginning to do more and more, maybe because I'm in a, or most of us in this meeting are in an urban practice, is that HRT is becoming an important component in females in the postmenopausal and the replacement therapy section. So in females of patients of mine who have keratoconus and are moving into that age bracket, I do make it a point to tell them, even if they have not considered HRT and they're not on HRT, I keep telling them that it is something that should be kept in mind. So actually my bar for progression, which was generally at 40 years, has now moved even further, because we have patients wherein beyond 40 years also we have seen, but we may not need to be very aggressive in our follow-up as we are with our younger patients.
I think that's a very valid point. And whenever we talk, he rightly picked it up that whenever we are talking about any literature, whenever we are talking about any average, that's the average of the pool data, whatever they have. But it may not apply to an individual setting and right in front of you. That can only apply that you may have some idea, but unless you see the trend in that individual, well, you cannot be very sure that it's fine. So he rightly said that it's better to follow up a case longer rather than shorter and be sorry about it. Having said that, whenever we do the follow-up and if we do not see any progression, possibly the next follow-up can be a little longer. We do not see progression, next follow-up can be a little longer, and possibly later on we can just do an annual follow-up, which is not asking too much from the patient. Thank you, Dr. Vinayak, for that wonderful tip. And before I end, I'm going to just touch upon one interesting concept which we rather wanted to start with, but because of the paucity of time, we moved ahead with other discussion. So this concept which I'm talking about is the concept of something called final destination. The final destination, when we talk about, we are talking about what practical final achievement or destination which we are looking at in this particular patient. Now, when we talk about final destination, we have to look at something that the final outcome, visual outcome, or whatever outcome you're looking at should be practical outcome. Like in this case, patient was asking, can my right eye be as good as the left eye? Possibly not, because that eye was amblyopic and we may not be able to achieve. So as a surgeon, we should know what is the practically achievable outcome here finally. We should also know the timeline needed to reach. Praveen touched upon that in such kind of cases with axial myopia, whenever we do treatment, it's going to take longer time and it may be pushed by 1.5 years. Unless we tell this to patient, it's incomplete treatment. Third thing, we must know about the steps taken to reach the final destination. If we do not know ourselves that what are the number of surgeries which we are going to do to reach there, and there may be more than one route to reach there. As Dr. Fogla was talking about, that there are multiple ways of treating such kind of patient using ICRS, using phakic IOL. We must know on day one, what are the ways to reach to our final destination, what is the time involved, and what is the monetary aspect of this thing. Let's do a small role play here before we close down. So may I have both Indrajot and Vishwa here? So here, yes, in this role play, Vishwa is a traveler and Indrajot is a travel agent. So go ahead, Vishwa, and what do you want to do?
Vishwa? Thank you, sir. So, ma'am, I would like to go yes, ma'am, I would like to go to some exotic travel location for my holiday. Can you please guide me? Yeah, where do you want to go? Do you have any place in mind? Yeah, ma'am. Maybe I was thinking moon. Moon? It is very unrealistic. Okay, let me book a flight for you to Doha. Ma'am, Doha.
I don't know what I'll do in Doha. Will I enjoy in Doha? Is it exotic?
Yeah, your flight is going to be very comfortable. And I have sent many people over there. You can go and it'll take, tomorrow, can I book a flight for you to Doha? It'll take around about 20,000 rupees.
Ma'am, but after Doha, where am I heading to? For how many days?
Don't worry, we'll plan that later on. I have a friend, I'll connect you and then later on we can plan it.
That's fine, ma'am, but I really do not understand how will I enjoy being in Doha or then connecting to some
Your
other
flight is
travel
going to be
agent.
very smooth, very smooth. So I think you should go pack your bags and just plan for it.
I think I would like to contact some other travel agent, ma'am. Thank you so much.
So I'm here, Vishwa. Ma'am, we run a company and we have a perfect holiday for you. So my plan is that I'll book a flight for you day after tomorrow for Doha. And from Doha, the flight, there's a transit. And from there, you will go to San Francisco. From San Francisco, your final destination is Hawaii. The entire travel is going to take 2 days time. The cost involved is around 3 lakh one way. This does not include the stay there. If you want, we can plan the backwards journey also. It's very simple. Along with this thing, if you want to have a different journey, we can plan instead of Doha, we can possibly go to Egypt, and from there we can plan to go and we can take a break. However, the journey will take a couple of more days time and the cost involved would increase by another lakh of rupees. So what do you want to do?
Thank you so much, sir. This sounds like a plan. I would like to go with the first item.
Thank you. So this is exactly how we end up doing in most of the cases, or not most, many of our cases. We end up saying that cross-linking, we'll do cross-linking immediately, but we do not talk about the final destination, what we want to achieve, where do we want to reach, and how much time and whether it's required or not. So if we all have this habit of noting down the final destination, time achieved, steps needed to achieve that, and possible options, well, that would complete the entire treatment. So with this thing, I would like to close this case, and I would like to invite Dr. Vikas Mittal for his final closure.
Yeah, thanks so much, Himanshu. It was really wonderful once again, as we have expected. Just 1 minute. Can I just share my... Okay, so I think this was a different kind of format, and we tried to make it semi-formal, and we just they were not too much into surgery. We wanted to discuss what we generally discuss in the clinics, and how we make decisions, and how do we deal with patient. So that was the basic aim. And I did one thing is quite clear from all the discussions so far, is that we need to think holistically, which procedure, what timing, and also counseling is very important. As we have seen in the last role play, it's very important. We need to take family into confidence, we need to take patient into confidence. Like, the discussion in the clinic needs to be pretty high, pretty good, pretty quality, and that's why we had patient also in this particular format. We also came to know that there are many gray zones. What is the exact progression, how do we define it, what do you cut off, which protocol, pregnancy, which hormones, repeat CXL, so many. And Dr. Vinay Agrawal time and again he highlighted that Indian literature is inadequate. So is it that we if there are so many very, very scanty reports, but we all individually see these patients, so is it possible that maybe we all can collaborate? We are exploring this option that maybe we all can share our cases and then actually come out with a great literature. With this, I would like to thank our panelists for sparing your time, sharing your expertise, and enlightening us. I also like to thank Himanshu. Himanshu was a main brainchild behind this whole format. My co-moderators, Purvasha and Himanshu, the cornea specialist, Charuta, Sonia, and Akanksha. The general ophthalmologist role was played by cornea specialists, Dr. Darshna from Gujarat, Devpriya, and Indrajot from Punjab. The patient role was played by our fellows, Yatri, Vibha, and Vishwa. There was a very good literature review team, and Dr. Abha, who could not join today. She's from Shroff, and she was also in the literature review team. Then Devpriya, Darshana, Indujot, and our fellows. We enjoyed, preparing for this meeting. We had multiple meetings in the evening, late in the evenings. I also would like to thank Pritam Kumar, CL expert from LUPI, and Dr. Shalini, who prepared a good video for us in anesthesia. So with this, we come to an end, and thank you so much, everyone. Thank you so much, Hallmark team, for backend support. And I would like to thank Geeta, our president, who has been very proactive in all this ECME series. She was very supportive. I discussed with her many times that we are planning to have another format, and she was very, very, very supportive. So with this, thanks once again, the panelists and everyone, you all who joined on Sunday, and sparing your time. Thanks so much, and see you soon.
Thank you.
Thank you. Thank you, everyone.
Thank you, Dr. Vikas. Thank you.
Thank you, Dr. Vikas.
Enjoy the rest of the Sunday.
Are you there?
We are all set.
Oh, you're on phone. Okay. Thank you, Geeta. You were out still joined from the phone. That's nice of you.
Wonderful show, Himanshu.
Vikas is the...
Thanks
And
so much.
Vikas, yeah.
You could join on Sunday. Thanks so much.
Very nicely conducted.
Rajesh did convey it loud and clear. I think next time onwards we will have Saturday. We will not have.
We'll have it on Saturday evening, so that we all can.
And all rest
yeah,
of.
Great job, all of you. It was very interesting, and I think we'll have a lot of good feedback, and it was very practically oriented, and I think a lot of important points were covered in this Kerakonnect. Excellent.
Yes, thanks so much, Dr. Fogla. That was very interesting. Thanks so much.
Huge team effort, I think. Everybody did a great job because under your guidance.
True, very true. Because his entire team, they were like every day awake till late night, and coordinating between many people was not so easy. Because great job, your entire team. Congratulations to you all.
Yes, thanks so much, everyone. Thanks so much, everyone, for hanging around for all late evening meetings. Thanks so much. So let's leave now and enjoy your Sundays. Thanks so much. Bye, everyone.
Thank you so much, everyone. Thank you so much, Dr. Himanshu, for guiding us. It was wonderful.
अभी सारे चले गए हैं हिमांशु, आप कोई बात कर सकते हैं तो अभी 1 मिनट को पहले मैं देख लूं 29 still there.